Okay, so good afternoon, everybody.
Yeah,
On
you
behalf
start.
of
Introduce.
good afternoon, everybody. On behalf of Jaslok Hospital and General Practitioners Association, Greter Bombay, I welcome you all to this 295th webinar. Without much ado, now may I request our Dr. Senior Practitioner, Dr. Meeta Adia, who is an active family physician at Pedder Road, going to moderate today's session. So
Yeah, I get body eye.
may I now request Dr. Meeta Adia.
Yeah, thank you. Can you hear me?
Yes.
Yeah.
Yeah. So, Dr. Nikesh Jain is a consultant at interventional cardiologist at Jaslok, Bhatia, Saifi, Bridge Candy, Global, Masina, Wokhard. And he has excelled in field of interventional and non-interventional cardiology with 10 years of experience in field of cardiology. He cleared DNB medicine and DNB cardiology from Jaslok in first attempt. He has contributed to various textbooks. He has written chapters on complex coronary issues on left main, chronic total occlusion, constrictive pericarditis, anomalous coronary artery intervention. Has published many articles in peer-reviewed journals. Has been awarded Amar Gandhi Award for Best Resident at Jaslok. He is the team of Tower at Jaslok Hospital. His special interest is complex coronary interventions, TAVR and other SHD, heart failure, and heart transplant workup. And now I'll request Dr. Jain to have his address.
Sure.
Anyway, I forgot to wish everybody Happy New Year and good afternoon to Dr. Dolakia, Dr. Bhatt, and Dr. Nikesh. Sorry for the
WhatsApp करूँ ना WhatsApp करूँ Yeah. So thank you very much, Dr. Meeta, for a kind introduction. So today I'm taking a very basic topic like the role of statins and its role in prevention and secondary prevention in atherosclerotic cardiovascular disease. So being a family physician, you also will come across this common dilemma, like when to start with this statin therapy, when to continue, how to continue, and regarding the doses. Because what happens is when we start a very small dose of statin, and if we don't achieve our LDL targets, which has been revised, like to try quite a drastically low levels for Indian guidelines that I'll come across. So if we don't update those guidelines into our practice, then there is no role for prescribing a suboptimal dose. So that's what we'll discuss and learn about today. So just regarding the scenario, so as you all know, as Indians and Asians, okay, we have a tendency to develop atherosclerotic cardiovascular disease about a decade earlier than the Western population. Okay, just because of the genetic makeup that we have. 50% of the coronary artery disease in India occurs before the 50 years of age. And as you all know, considering the lifestyle changes that has been happening, almost one third of the population are happening before the 40 years of age, with many presenting young MIs who are presenting with sudden cardiac death. So that is why the awareness and prevention of such risk factors are quite important. So in India, non-communicable disease burden, which is cardiovascular disease, respiratory diseases, cancers, they're all increasing in a dramatic manner. And specifically with cardiovascular disease, which is contributing to much more, almost 54.5 million. Okay. So as decades pass by, the incidence, prevalence, and the risk factors and the occurrence of cardiovascular disease will be much more. It will be like a pandemic. So according to the ICMR study, 82% have dyslipidemia. The pattern of dyslipidemia in Indian subset is completely different. Okay. So if we go by this low HDL at the bottommost line, if we see the lipid profile, the low HDL will be present in almost 65 to 70% of the patients. So merely having a normal total cholesterol levels or hypertriglyceride levels is not amounting a normal lipid profile report. Even if the HDL is low, that also amounts to abnormal dyslipidemia report. Okay. Studies have clearly shown that LDL cholesterol is a major driver for atherosclerosis. Okay. 24% will have cholesterol levels of more than 200 and triglyceride levels of more than 150. That will be in 31/3 of the patients. In Indian patients, what we have regularly seen is the LDL levels are not so high. They are just normal or high normal range, but they have high triglycerides. That is typical of high carbohydrate intake that we are amounting to. And the typical metabolic syndrome, abdominal obesity, insulin resistance, sedentary lifestyle. Okay, so this is all contributing to a typical lipid profile pattern of high triglycerides, normal or high normal LDL compared to the Western population, which will have definitely a higher LDL level compared to us. But still, we are at very high tendency to develop atherosclerotic cardiovascular diseases. So even if our LDL is low, okay, or near normal, we have what we call as intermediary LDL particles, which are very high in us. Okay, those are not measured directly in laboratory, but experiments have clearly shown that we have very high levels of IDL cholesterol, which is intermediate metabolic derivatives of LDL cholesterol. So that also contributes to atherosclerosis. So this is very important to remember. Low HDL also amounts to abnormal dyslipidemia pattern. Common pattern is increased triglycerides followed by hypercholesterolemia and followed by very high LDL levels. Okay. So elevated levels of LDL are the root cause of cardiovascular disease. All the studies have shown that our main target is to absolute reduction of LDL cholesterol and the duration of reduction. Not that if once we achieve a better LDL cholesterol, we start reducing the medications or the patients can be relaxed on their lifestyle to increase the LDL and again having fluctuating LDL levels. So absolute and sustained reduction is important. Okay. Coexistence of hypertension and other risk factors like diabetes almost triples the risk of cardiovascular disease along with dyslipidemia. So each risk factor has a compounding effect, has a multiplying effect on developing atherosclerotic diseases. Okay, so every 1 millimole, that is every 39 milligram reduction in LDL cholesterol, it reduces the cardiovascular risk by 28%. Okay, whatever medications you use, statins, fibrates, ezetimibe, bile acid resins. Okay, so there is definitely a dictum, lower the better. Okay, lower the LDL cholesterol, more maximum benefit that you will get in atherosclerotic cardiovascular reduction, and it has to be a sustained reduction. As you see in diabetes, it has to be a sustained HbA1c reduction and a sustained HbA1c of less than 6.5 in all the diabetic patients. That only the patient will have microvascular and lesser macrovascular complications. Similarly to that, it's similar for LDL cholesterol as well. So considering the issue of increasing atherosclerotic cardiovascular disease in young Indian patients and considering our different genetic makeup, we had our own lipid guidelines in 2023, Lipid Association of India in 2023. So this will summarize everything that you want and the targets of LDL cholesterol also. So overview, just to have a brief overview, I'll give come to in detail in later on. So it provides us population specific guidance for dyslipidemia, means it is stratifying the risk population, okay, into severe, mild, moderate, very severe risk categories. And depending on that, they have categorized the amount of LDL reduction. Like for example, for very high risk patients, they have recommended for LDL reduction of less than 50. For high risk patients, less than 70. Okay. And to start with, we have to start with moderate to high intensity statins for high risk and very high risk groups. Okay. So high intensity means 20 to 40 milligram of rosuvastatin and 40 to 80 milligram of atorvastatin. So this is the risk modifiers and risk categories which the Lipid Association of India recommends. So the risk factors are divided into three categories: major risk factors, high risk factors, and risk modifiers. Major risk factors means age low more than 45 males, okay, and 55 females, cigarette smoking or tobacco use, high blood pressure, and low HDL cholesterol, which is the commonest pattern in India. Okay. High risk factors means there is a family history or there is a history of premature atherosclerotic cardiovascular disease in family, or stage 3 or stage 4 CKD, hypoprotein, elevation of any single risk factor, lipoprotein more than 50, metabolic syndrome, as I told you, and the coronary artery calcium score, like mild calcium score of 99 or less than that. Risk modifiers means other risk factors which are mild, increased waist circumference, CRP, triglycerides, other inflammatory disorders like rheumatoid arthritis, premature menopause, air pollution. Okay, so depending on this risk factors, we divide the patients into risk groups. Low risk, that is 0 to 1, major risk factor, and LDL of around borderline high normal LDL, and HDL, which is non lifetime CVD risk of less than 30%. So this lifetime CVD risk is an online calculator that will give you a 10 years lifetime CVD risk, and it is calculated as 5%, 10%, 20%. Okay. So low risk will be 0 to 1. Okay. Overall high normal LDL cholesterol. Okay. Moderate risk, that is two major risk factors, that is amongst the first column which is there. Okay. LDL, which is definitely higher. Okay. And non-HDL cholesterol is also higher. And low risk group with more than one risk modifier. Okay. So these are the risk modifiers which are there. And atherosclerotic cardiovascular risk of more than 30%. Okay. High risk is again more than 3 risk factors, LDL way up beyond 160, diabetes. So diabetes per se, diabetes, even if it's present as a single risk factor, it is equivalent to a coronary heart disease equivalent. Means it is such a bad disease that it is amounting as if the patient has had a heart attack before. Okay. So definitely it's a high risk for even a single risk factor. Very high risk means diabetes with target end organ damage, coronary artery calcium score of more than 100, more than two high risk factors, and heterozygous familial hypercholesterolemia. Okay. Extreme risk means category A or category B, high calcium score, homozygous familial hypercholesterolemia. So this heterozygous will have LDL of between 300 to 500. Homozygous will have a LDL of more than 600, 700. Okay. So extreme risk means patient who has already had atherosclerotic cardiovascular disease in the past. Okay, those are considered to have atherosclerotic risk factors. Okay, so see, this is difficult to remember this chart. We cannot memorize this chart completely. Okay, but we can just apply some common logic that yes, if the patient has single risk factor, or okay, though he may land up in low risk, but if the patient has a family history of premature atherosclerotic disease with high normal LDL, he will fall into moderate risk. And similarly, if the risk factors are keeping on adding, okay, diabetes, hypertension, coronary calcium score, the risk keeps on increasing. Okay, so just apply common logic, one risk factor, two risk factors, family history, previous history of heart disease, and you can just categorize your patients into respective categories. Okay. So these are the common risk factors that should be kept in mind that have encircled in the red bars. Okay. So just go through the common risk factor the patient has, and you can stratify your risk patients completely. So coming to the treatment targets. Okay. So if the patient is into low risk group, okay, the target LDL is okay. ApoB should be less than 90. Secondary target. Moderate risk group, it should be less than 100 or less than 70 will be better. High risk group, definitely less than 70. Very high risk group, less than 50. Extreme risk group A and B, less than 50 and less than 30. Okay. And option is less than 10 to 15 also. Okay. So as I told you, lower the LDL, which is better. So I'm just coming to the previous slide. Okay. Low risk group less than 100, moderate less than 100 or less than 70 preferable. And then as you go with the risk categories, less than 50, less than 30, and maybe 20s or 30s or 15 also. Okay. So once you start a statin, always identify a risk group and the respective LDL target. Okay. Just don't start with 5 or 10 milligram and just forget about the target groups in such patients. So coming to the management. Okay. So whenever a low risk group or a moderate risk group has an LDL of more than 1100, so irrespective to say that the lifestyle interventions will always come first. Okay. So for low risk group, if the LDL is more than 100, we can try with lifestyle interventions first. And if it is persistent, yes, then we can add on statin therapy. Moderate risk group, lifestyle intervention plus moderate intensity or high intensity statin. Target is to reduce the LDL cholesterol of less than 100 or 70, and we have other medicines to add if the target is not achieved. Coming to the high risk group categories and beyond, all the patients need moderate to high intensity statin therapy to start with, okay, not to up titrate it. Week 4, repeat your lipid profile with ApoB. If the goals are achieved, yes, you can continue with the same dose. Okay. Triglycerides, fibrates can be added on day 1 if the triglycerides are more than 500. Okay. Depending on the target on week 8, which has achieved or not, then you can add other non-statin therapies, which will come across like ezetimibe. Nowadays, we have injectable agents, okay, which is Repatha, inclisiran, okay. So as I told you, you can just see this, the common lines. To reduce the LDL cholesterol by 30%, start with moderate intensity statin therapy. To reduce by 50%, which is usually achieved by high statins, 40 of rosuvastatin or 80 of atorvastatin. To achieve more reduction, you can add ezetimibe. Okay. And to achieve more additional 10, 15 to 20% reduction, you can add bempedoic acid. Okay. And for more reduction, add-on therapy is PCSK9 or Repatha. Okay. So it is just an additional therapy with different mechanism of action that you can come across with different statin therapies. So moderate intensity that we commonly use atorvastatin, okay, is 20 to 40 and high intensity is 40 to 80. And rosuvastatin, which is we commonly use, is 10 to 20 and 20 to 40 of high intensity. Okay, so we can just make a chart also. You can just take a printout of this. You can start with your high risk categories patients, whether you have started on low intensity, moderate or high, and you can just calculate what is the LDL reduction that you have achieved in 4 weeks or 8 weeks. So it is a risk-based stratification for initiation and titration of therapy. Preferred is atorvastatin and rosuvastatin, both are almost equal. But yes, rosuvastatin is sometimes preferred considering its hydrophilic, potent and long half-life. Addition of other non-statin therapies, ezetimibe, bempedoic acid or PCSK9 if LDL targets are not met. Asian patients often achieve targets with lower doses, like Indian patients. That is why majority of the patients, you will find that even on 5 or 10 of atorvastatin or rosuvastatin, the LDL is well below 100. Okay, so don't always target with very high doses, but yes, for a recent event, always start with high doses. You can down titrate it later on once you achieve your targets. Okay, so coming to lipid management in chronic coronary syndrome, which is stable atherosclerotic cardiovascular disease, means a patient with a past event, stable coronary artery disease. Okay, so start with rosuvastatin of 20 or atorvastatin of 40. And if LDL is still on the higher targets, yes, add ezetimibe that is more than 55 or non-HDL of more than 85. And if it's achieved of less than 55, because it's an established coronary artery atherosclerotic disease, so targets of LDL are less than 50. Okay, so definitely we have to target less than 55 or so. Acute coronary syndrome, yes, definitely we have to start with high intensity therapy. Okay, so if the patient is already on naive patients, you can start with high intensity therapy. If the patient is already on high intensity statins, monitor LDL levels. Okay, if the target is achieved, yes, continue with that. If the target is not achieved, LDL of less than 50 or less than 30 as needed, add ezetimibe and other agents like bile acid sequestrants, bempedoic acid, PCSK9 inhibitors. Okay. So mechanism of action of various lipid lowering agents. Statins, as you know, acts on the HMG-CoA receptors, reductase enzyme. Okay. Ezetimibe acts on the intestinal level, acts on this NPCL enzyme inhibitor. Inclisiran acts on this silencer RNA, which is related to the LDL receptors. Repatha, which is evolocumab, it acts on the LDL receptors. It's like an antibody to the LDL receptors. Like we have a lot of monoclonal antibodies in rheumatoid arthritis patients and other arthritis patients. We have this evolocumab for LDL receptor. Okay. So as I told you, both atorvastatin and rosuvastatin are having equal benefits in cardiovascular disease reduction, though rosuvastatin may have some more benefits regarding hydrophilic, less muscle penetration, okay, and long half-life also, and more potent also. And in few studies, in Jupiter study, it has shown that the hsCRP levels, which is a marker of inflammation, has shown to have better reduction with atorvastatin compared to atorvastatin. Okay, don't forget the pleiotropic effects of the statins, be it atorvastatin or rosuvastatin. Anticoagulant effects, reduce inflammation at the coronary plaque, improve endothelial function, and inhibition of platelet aggregation. Okay, so even if you're prescribing statins in a very small dose, we usually achieve for this pleiotropic effects. Okay, I'll come to that later on also. Even if the patient is statin intolerant, having myalgia, okay, you can start with very small dose of statins for this pleiotropic effects and add non-statin drugs to achieve LDL reduction. Adverse effects, as you all know, starting with simple myopathic pain to severe myositis and rhabdomyolysis, elevation of AST and ALT levels, renal failure. Okay, so definitely these are the side effects which need to be monitored regularly at interval intervals, specifically in old age patients, CKD patients, liver disease patients. So those will be more prone to this myopathy and rhabdomyolysis. So as usual for any other contraindications, hypersensitivity to any statins, pregnancy, breastfeeding, acute liver disease, a persistent elevation of serum transaminases is a contraindication for statin therapy. Okay, so as I was telling you regarding the inflammatory markers, okay, so even a low dose statin has demonstrated a significantly greater percentage of LDL reduction and the inflammatory markers. So even if the patient is non-tolerant, having myalgia, start with low dose statins. At least you will get some pleiotropic effects because of that. Secondary endpoints was definitely better compared to other non-statin therapies and herbal therapies. Comparing rosuvastatin with other statins, so as I told you, it has almost a greater reduction compared to a lower dose. So 10 milligram of rosuvastatin is equivalent to atorvastatin of 20 milligram. Okay, and similarly 20 versus 40. Okay, that is why this comes in 10, 20, and 40 versus atorvastatin comes up through 80 milligram. Okay, so dose-related achievement of LDL goals were also better. Okay, with rosuvastatin compared to atorvastatin. So compared to all the other statins, simvastatin, atorvastatin, and pravastatin, okay, the rosuvastatin achieved a much greater reduction, okay, of LDL cholesterol compared to other statin therapies. Okay, so LDL reduction by statin doubling, definitely hydrostatin was needed in few subsets of patients, as you know. So with doubling the dose of rosuvastatin, there was a more than 50% reduction compared to the other molecules, which achieved lesser reduction of LDL cholesterol. Okay, even with PEPI study, it showed similar events, reduction in CV events, as well as greater reduction of CV events and LDL cholesterol as well. Coming to the pleiotropic effects of statins, as I told you, coming to the endothelial level, reducing the endothelial inflammation, reducing the plaque inflammatory state. And it is also shown on based on IVA study. If you have a persistent LDL reduction, as I told you, persistent is important. It has shown to have reduction in the atheroma volume and area reduction and increase in luminal gain. Okay, as you know, some patients when we do angio and we have persistently good LDL reductions, and those 40-60 patient plaques have sometimes regressed in some patients to just 10% or 20%. So it is not a myth, it is a fact that persistent LDL reduction, good lifestyle can lower your atheroma volume and plaque burden. Okay. Anti-inflammatory effects, as we discussed, it acts on all the leukocyte adhesion molecules, macrophage infiltration, which is a major marker of endothelial inflammation. Okay, adding ezetimibe, that also has an additional anti-inflammatory effect. So all the statin molecules except ezetimibe and fibrates, they all have an additional anti-inflammatory phenomenon, reducing the plaque burden, having plaque stability, so that the patient doesn't have acute coronary syndrome. So definitely in acute ischemic stroke as well, it is shown to reduce reoccurrence of acute ischemic stroke and hemorrhagic transformation. So be it MI or stroke, definitely statins with moderate to high intensity are recommended. So as I told you, there was one study which showed that the CRP levels reduction were much better with rosuvastatin compared to atorvastatin. So it reduces overall inflammation, body inflammation much better compared to atorvastatin. And it also translated to the reduction of CV risk as well, not only with lab value, but also with cardiovascular reduction. In Jupiter trial, it also showed that time to first occurrence of CV death, non-fatal MI, it also showed a delay in the occurrence of the first event. Okay, so definitely, and the numbers needed to treat were much more. Okay, it was less than 150 and 55. Asteroid study, as we discussed, greater the LDL reduction, persistent LDL reduction, the atheroma volume also reduced. Like in this example, it reduced from 10.63 to 6.99 millimeters. From 19 millimeters square area, it increased to 17.3. So it has definitely a luminal gain benefit. The luminal gain from 8.4 to 10.32. So as we have discussed regarding the categories of patients, how to start the statin therapy, okay, and we'll come to some clinical based examples, common clinical scenarios. Okay, so this is a common example at 40 years old male, diabetic, hypertensive, ISD, no complaints at all, routine health checkup. The LDL cholesterol is 147. So lipoprotein A is also normal. So what should we do? The target LDL is 100, 70, or what is it like? So first step is to categorize such patient. 40 years old male, asymptomatic patient. Okay, there can be two thoughts on this. No comorbidities, no family history. LDL is 147. From my side, I would like to target LDL cholesterol of less than 100, definitely for sure. Okay, but first and foremost, I would like to target this patient with lifestyle measurements first. Lifestyle interventions are a major driver, okay, because if the lifestyle interventions are not followed and not persistent throughout their life, even if I start a statin, the patient will still be at a atherosclerotic risk. Okay, so always stress upon lifestyle interventions and then give it a trial, because patients also get motivated, okay, so that the patients don't have to start medications in future and they can more have a healthy life, over a healthy cardiac life as well. So options, lifestyle only, rosuvastatin, atorvastatin, and pitavastatin. Okay, because the patient is a low risk category, so we can start with mild intensity statin therapy, not a moderate to high. I would take lifestyle only as first option, but opinions may differ. So let's categorize. So LDL is definitely high. Okay, it is 147. Ideally, the patient is falling into the moderate risk category. But as I told you, I would still go for lifestyle, or we can start with lifestyle plus moderate intensity statin therapy, depending on the compliance of the patient, depending on the previous lifestyle of the patient. If the previous lifestyle of the patient is good, is already having an healthy lifestyle intervention, then we can directly start on statin for such patient. But if the patient lifestyle is not good, he's not exercising, he's already having a lot of outside food, the lifestyle is not good, the eating habits are not good, yes, I would like to give lifestyle interventions first and then try on statin therapy after 3 months or 4 months of intervention, lifestyle intervention. Okay, so coming to the case one, yes, we can either start a lifestyle or low dose statin therapy. Coming to the case two, okay, same 40 years old male, okay, no diabetes, hypertension, no complaints. Okay, lipid profile is still showing 147 in spite of lifestyle medications. Yes, definitely. Then we have to start with lifestyle therapy along with statin therapy. Because this patient will risk on high risk group. Okay, then start with moderate intensity therapy and should target LDL of less than 70. So coming to this case three, same patient, same age, but yes, there is a diabetes history. So as I told you, presence of single risk factor, that is diabetes, amounts to a patient falling into high risk category. Okay, so definitely we would like to target LDL of less than 70 or so. Okay, so diabetes, even without target hormone damage, patient will have a high risk. Okay, and the target will be less than 72 or 40. Okay, so I would directly start with moderate to high intensity therapy for him. Okay. Coming to the case for diabetes, already has established PTCA to LED 1 year ago, which is patient already has an established coronary disease with diabetes mellitus at a young age, definitely the target will be much lower, less than 50 or 40. LDL targets are already not achieved. Okay, directly we'll start with high intensity therapy. The patient is falling into extreme risk category A. Okay, so atherosclerotic disease is already there. Patient had an LDL angioplasty, plus patient has diabetes. So there is already one high risk group plus established disease. So what should be the target? Less than 50. Okay. So in spite of this rosuvastatin, atorvastatin, okay, and if the patient after 4 weeks of, as I told you, we have to monitor every 4 weeks and then after 8 weeks, and see the target. LDL has changed from 147 to 97. But as we discussed, the target is less than 50. So what should we do now? Okay, either we can increase for 20 to 40 of rosuvastatin, or we can add bempedoic acid or PCSK9. Okay, so as we discussed, bempedoic acid is a mild agent. It will have only 15 to 20% of reduction, but will not achieve the target of 50. So better to start with PCSK9 inhibitors. Coming to this, PTCA 3 years back, diabetes, hypertension, multiple risk factors, recurrent coronary events requiring multiple angioplasties, atherosclerosis elsewhere, femoral plus carotid. Already on moderate intensity therapy, I would say rosuvastatin plus 10 of ezetimibe. He has reduced LDL from 147 to 97, which is almost, you can say 30 to 40% reduction. But this is not a target. This patient will fall into multiple risk factors, multiple coronary events, and plaques everywhere. So this will fall into the category of category B. Okay. So what is the target for category B? Less than 30. So definitely patient will go on for moderate intensity therapy with PCSK9. So this is how we can roughly categorize our patients into different categories and target our statin dose or non-statin therapies. This is a common scenario you can see. Many patients are not physically active. The muscles are already weak. Many are vitamin D deficient. Okay, and starting even a small dose of statin, 5 milligram, patient develops myalgia. Okay, so what should we do? The first step in any patients who develops myalgia, do a CPK level. CPK level will tell you whether the patient has myositis or not. If the patient has myositis, definitely you should stop the statins, wait for a couple of weeks for statins, those TPK to normalize, okay, and then either challenge with another statin or have non-statin therapies. Okay, so this is a simple chart. Check the CPK levels. Okay, if it's less than 4 point of less than the upper limit of the normal 4 times, stop statins for 2 weeks. You can give a statin re-challenge or find other causes like vitamin D deficiencies, vitamin supplements. Okay, you can check other causes as well. If it's more than 4 times the upper limit of normal, you have to stop statins for 4 weeks. Wait for CPK to normalize. Either change the statin or reduce the statin like couple of 2 or 3 days a week or so. Okay, or start with pitavastatin. This can be added or switched over to that because pitavastatin is shown to have lower effects of myalgia and myositis. So you can stop rosuvastatin or atorvastatin and try with pitavastatin. And if LDL goal is achieved, continue same. Okay, rhabdomyolysis, it's like an anaphylactic reaction to any medicine. Don't start statin at any cost in future. Okay. So definitely clinical implications, because why these guidelines have been made separately? Because as we told you, South Asians are at high risk of premature disease. Rosuvastatin's high potency, even at low doses, is ideal for Indian lipid profiles, encouraged as first line or very high risk patients. And it is widely available now. Multiple brands are available and with economical cost. Okay. So as I told you, explore the anti-inflammatory properties of various molecules. As you know, in diabetes also, now the target is more of giving molecules which have cardiovascular benefits, not only like sugar control molecules like sulfonylureas, which we used to prescribe commonly. Okay, so even a small dose of statins, if the patient can tolerate with dyslipidemia, along with non-statin therapies, at least the anti-inflammatory properties of statins should be utilized. Integration into personalized medicine using genetic risk scoring as well. Further research on the role in non-cardiovascular diseases like Alzheimer's, CKD progression is also underway regarding the role of statins in other diseases. Okay, so don't hesitate to start statins. Lifestyle interventions always play a role. They will give motivation to patients so that they can avoid medications. And even if parameters are controlled on medications, be it diabetes, cholesterol, or BP, if diet and life walking is not there, if exercise is not there, patient will still be at cardiovascular disease risk. So always encourage patients to adopt healthy lifestyle. And then comes the medical part. Thank you. We'll take the questions now. Dr. Dulakia?
Yeah, there are some questions.
Yeah.
Does sugar and sugary products increase cholesterol?
So definitely yes. So whatever Indian diets are very more in carbohydrates. Definitely more of carbohydrates, it gets converted into triglycerides and cholesterol as well. So not per se total cholesterol, but definitely a triglyceride will shoot up a lot. So definitely sugar and sugary products are definitely not recommended. They will increase the risk of hypertriglyceridemia, diabetes, okay, and your abdominal obesity as well. So definitely it is not recommended to have more in sugar and sugary products.
So what is the importance of extended lipid profile? How to interpret?
So extended lipid profile, it includes ApoA and ApoB. Okay. So what happens is, like, as I told you in our Indian scenario, LDL is normal or high normal. Okay. So what we do is we sometimes, if there is a family history of premature disease, there is a previous event which has happened like minor TIA or a hypertension patient has diabetes as well. So if the ApoA and ApoB levels are high, then irrespective of the LDL, if it's 100, 130, we try to reduce it more to less than 70 or so. Okay. If the patient has risk factors along with ApoA, which is very high. Okay. So that is the target of doing extended lipid profile.
But if no risk factor and no history, then also we
then we can just see, because there is no treatment for high little lipoprotein A levels. Inclisiran is a molecule which has shown some benefit in reducing your apolipoprotein A levels, but studies are yet to prove that it is translating into clinical benefits. Studies have clearly shown that even if the lipoprotein A is reduced, okay, there are no translating into clinical benefits like reduction of MI or stroke in future. We still need more studies to prove that. It's just a surrogate marker that the patient will be at high risk for atherosclerotic disease. Okay, so if it is present and if the patient has other correlating risk factors, we can target the LDL reduction to less than 70 or so. Okay, so that is the only benefit in measuring extended lipid profile.
is a patient with history of premature coding. In patient, what should be the lifestyle?
So definitely, for as the dictum goes, for every non-communicable diseases, any atherosclerotic diseases, whatever is made outside has to be avoided. Big packed food, preserved food, refined flour products. Diet should be more of fruits, vegetables, and regular exercise. The minimum recommendation is at least 45 to 60 minutes of brisk walking, at least 4 to 5 days a week. So this is the basic dictum that everyone has to follow and patients has to follow. Okay. So more of homemade food, more of fruits, vegetables, salads, that, and whatever the junk food, refined, the oil should be more of polyunsaturated like olive oil or any vegetable oil which is preferred. So definitely it has more implications rather than just switching into medications.
Importance of non-HDL in 12 hours fasting required for lipid profile.
So there was a recent controversial data by the AHA that even non-fasting lipid profile will help, but I would not suggest to do that, because what happens is specifically the triglycerides, they are very fluctuating. Okay, so what happens is so the triglycerides will be more compared to the fasting lipid profile report. Okay, and what they do is they derive this LDL cholesterol from triglyceride level. They have this formula. Very few labs sometimes they don't do this direct LDL measurement. They do this derivative by a mathematical formula. So that also gets altered. So always do a fasting lipid profile. Non-HDL cholesterol is just the total cholesterol minus the HDL cholesterol. So it's just an indirect marker for atherosclerosis. So definitely do a 20 to 12 hours fasting lipid profile. Okay, non-HDL cholesterol is just an indirect marker if this value is more than 150 or so. So that is just a mathematical formula. Go by LDL, okay, go by HDL and do a fasting lipid profile.
Okay. Can we raise rosuvastatin 40 milligram for plaque stabilization?
So in acute coronary syndromes, we definitely give high dose statins for plaque stabilization. Okay, in recent unstable angina, in recent NSTEMI patients or STEMI patients. Once the patient gets stabilized, target LDL. Okay, if your LDL is less than 70, 100 with recent events or less than 50, as I told you, for very high risk patients, the plaque will get stabilized. No need to give very high dose persistently. It all depends on the LDL targets. Many, almost 30 to 40% of the patients, you will find that after 1 month or couple of months, patients don't tolerate high dose statins very well. They start having myalgia. Okay, so I think target LDL initially, yes, high dose statins in emergency cases, in acute recent cases, but down titrate to moderate intensity or add non-statins depending on the tolerability.
Injection Repat or inclisiran, does it act instantly?
So it takes couple of weeks to act. Okay, so basically Repatha is an injectable drug. Both are injectable, but Repatha duration is every 4 weeks to 6 weeks, and inclisiran uh, at one dose after 3 months and then every 6 months. Okay, so after Repatha will act in 2 weeks and even this will act in 3 to 4 weeks, and the effect is persistent. That is why inclisiran is every 6 months and Repatha is every 4 to 6 weeks. But in few patients I have seen Repatha, they act for persistent LDL reduction even for 2 months or 3 months. So what I do is I check LDL before the next dose. If it is low, I postpone the next dose of Repatha. So in 50% of the patients, you can find that the Repatha is required every 2 months, not even at 4 weeks, like 1 month. Okay, so you can titrate your doses accordingly.
Which statin is better for CKD and retinopathy?
So in CKD patients, some nephrologists are preferring atorvastatin rather than rosuvastatin. Okay, so they are suggesting more of atorvastatin rather than rosuvastatin for CKD patients. So we should switch over to atorva then rather than that, which is better.
And it's in a reduced dose, atorvastatin?
Tend to see it's a CKD. CKD itself is a very high risk factor for atherosclerotic events. So if the patient and CKD patients have a lot of myalgia as well because of other vitamin D deficiencies, calcium and phosphorus metabolism. So start with moderate to high intensity depending on the tolerability, and you can add non-statin therapies, but LDL has to be reduced in such patients.
In diabetics, which is the best statin?
Either one is good, but as we discussed in few slides and few trials, I would still prefer rosuvastatin over atorvastatin in diabetics.
Okay, 40-year woman with LDL 124, HDL good 70, otherwise normal. Is this level acceptable or start statin with lifestyle?
I would suggest lifestyle modification for
Lifestyle
this patient.
modification.
Yeah, because there are no risk factors falling into almost into low risk group. LDL is less than 130. So lifestyle modification is fair enough for this patient.
When we should check for hereditary conditions of hypercholesterolemia?
So there are different patterns of dyslipidemia with genetic pattern. Commonly, what we call as familial hypercholesterolemia, in which LDL is very high, which that we come across more common. So in that, as I discussed in one of the slides, that in heterozygous variant, LDL will be 300 to 400. Okay. In homozygous, the LDL will be more than 600, 700. We recently had a young girl of 7 years, okay, who had a family history because of consanguinity. Patient had a family history. 3 members were heterozygous, 2 members are homozygous. Okay, so the heterozygous patients had cholesterol of around 300, 400. And this homozygous girl, she had a LDL of 850. And she had to undergo an angioplasty to left main recently for that. So definitely, if the dyslipid pattern is like very odd, triglycerides of 1000, LDL of 800, 700, we should look for the genetic and the family history as well. And we
What are
should
the
test all the
clinical
family.
markers?
The
What are
clinical
the
markers, so what happens is in this very high levels of cholesterol LDL, there are xanthelismas. Okay, you can see the some papule-like things below the eyelids. Okay, on the tendinous surface, extensor surfaces of the elbows, what you call as xanthelismas. Okay, even if in old age there are some skin tags on the eyelids. So those are not a normal skin tags. Basically, there are markers of very high cholesterol levels.
okay. So how can we increase HDL?
So unfortunately, there is no medicine which can increase HDL. Only way to do it is good exercise and having food which are more in monounsaturated and polyunsaturated fatty acids like omega-3 fatty acids, walnuts, seeds. Okay, that we fish oils are more on omega-3 fatty acids. Okay, and dry fruits, all these nuts and seeds that we have commonly. So that is the only solution for that. Good
How
exercise,
important?
good healthy diet.
So how important is HDL?
HDL is definitely important. It is basically considered as a good cholesterol. So it basically acts as a reverse transport. So whatever LDL is there in our body, it acts as a transport mechanism to carry that LDL from our bloodstream to the liver back. Okay, so this is called as reverse transport. So HDL is very important. It acts in lowering the HDL from the body. Okay, so that is very important.
In case of PVD and DVT, can we use high potency statins along with cholesterol when there is non-healing non-healing wound is present on lower limb?
So definitely see peripheral vascular disease is a marker. It's a indirect marker that there's atherosclerosis in the limbs also. DVT is something different. DVT means there is a clotting in the legs, deep veins of the legs. So over there, the role of statins depends on the other risk factors. But yes, for peripheral vascular disease, high potency or moderate intensity statin with cholesterol is beneficial. We should prescribe it.
Is xanthelasma indication of starting statins?
No, not indicator, but yes, in the indicator of marker of underlying high cholesterol. But check your lipid profile analysis, patient's analysis. If it's high, definitely we should start statins. But this is definitely a marker of underlying dyslipidemia.
Any tachyphylaxis seen in statin like simvastatin or atorvastatin?
So I have not seen any like a tachyphylaxis like an anaphylactic reaction. But yes, if its patient has a rhabdomyolysis, which is equivalent to anaphylactic reaction, I've had 1 or 2 patients with rhabdomyolysis, but both the patients had after some sepsis or an acute kidney injury event, not to de novo event. So definitely when the patient has any secondary illness, sepsis, acute kidney injury, stop the statins for meanwhile. Okay, because it can precipitate rhabdomyolysis. Okay, but per se, after the first dose, any anaphylactic reaction, I have not seen any.
Does statin helps in reducing calcium deposition?
So there was a controversial study that it does stabilize the plaque, but in turn, it can in fact increase the calcium deposition. It stabilizes the plaque. Okay, so it may or may not reduce the calcium deposition, but definitely it will stabilize the plaque. So that role is very beneficial in that.
The same way, any food can increase LDL.
Yes, definitely all the like normally all the oily foodstuffs, processed food, packed food, outside food, definitely it will increase your LDL cholesterol and that has to be avoided. So egg yolk has to be avoided. The white part of the egg is fine. Chicken is okay, but red meat has to be avoided. That is very high fatty content. So that will increase your LDL more. Okay, so only the white part of the egg yolk has to be avoided. Chicken can be taken. Okay, lean proteins like lean meats. Okay, which is devoid of the fats, what we call. So that is recommended to have among the non-vegetarian foods. Role of exercise, as we stressed upon, it's more important. As you have seen, people have risk factors, but they exercise regularly. People are obese, they exercise regularly, and they don't have any event. Versus a person who doesn't exercise without risk factor will still have an event. So role of exercise and diet should not be underplayed. It should be stressed upon at every patient visit.
Xanthelasma in normal lipid profile. Should we give any statin?
So if patient has other risk factors, yes, target your LDL less than 70. Okay, but if it's completely normal, we can avoid statins. So target is LDL. Okay. So if the LDL is normal, even with a low statin or with the lifestyle, then there is no need for adding statin then.
Medicines to reduce calcium deposition.
So calcium deposition is basically lifestyle, good amount of exercise. It is more common in diabetic patients, smokers, and kidney patients. Okay. So if the patient has all these risk factors, try to avoid those. Otherwise, much of it is aging related problem. Few patients have tendency of calcium deposition even without risk factors. So nothing can be done about that. But if the patient has other risk factors, definitely we should tackle that.
Should a high risk person avoid fat completely, and what about carbohydrate restriction?
See, some amount of fat is important, okay, because it is required for our membrane function, some hormonal functions. So replace your saturated fat intake with monounsaturated and polyunsaturated fats, which is olive oil, all the vegetables oils which are there. Okay, replace your fat content with that, oil content with that, and consume in very minimal amounts, which is required for cooking. Okay, even if you avoid all this fried food stuffs, outside food, processed food, that also will be much better. Carbohydrate reduction, definitely yes, because this will give you empty calories. Complex carbohydrates are more important. All this refined for which is raw sugar, all this bakery products, biscuits and all, this will give you only simple carbohydrates without any nutrition. And this will increase the glycemic index. The sugar fluctuation will be also much more. So that is also not good for diabetic patients. Okay. So moderate amount of carbohydrates, okay, mild amount of fat intake with selection of your oil, that is more important.
So, yeah, I think we have done with questions. Dr. Dolakia. Dr. Dolakia. Dr. Dolakia.
I think his mic is off, I think.
Mute. You are mute. Unmute. Unmute. Dr. Dolakia. Dr. Bharat Bhatt. Dolakia. Unmute.
How often we have to repeat the lipid profile?
So in
Every 6 weeks or 3 months?
no, so for acute coronary patients, I repeat after 1 month, and if the levels are achieved, then I repeat every 3 or 4 months. But the initial lipid profile I do at 1 month. If the patient has a recent MI or any event, then I do it at 1 month, and then after every 3-4 months.
Yeah, routinely.
Yeah,
For
routine.
our
Yeah, for 1 year
routinely,
I do it. For routine patients,
if
if the levels are
yeah,
well controlled, for stable patients, then every 6 months to a year is fine.
yeah. When
Yeah,
we change the
yeah,
dosage, how
yeah,
to
yeah, yeah. So that's for sure.
6 weeks, six
Yeah,
months we do. Yeah,
yeah, because if the doses are set and if the
yeah,
last couple of lipid profiles are all normal, then we can do it every 6 months. Unless and
yeah.
until the patient has changed his dietary or lifestyle pattern completely, then we have to repeat it earlier, but otherwise not.
Any connection with the diabetic and this thing, cholesterol? These
So
people,
diabetes itself, because it's an inflammatory disease, so definitely it will increase your amount of ideal cholesterol more, and intermediary LDL that we cannot measure. So that's why in diabetes patients we target LDL of less than 70. Okay, so definitely, and diabetic patients have
yeah,
more triglycerides. The pattern is completely different, but still target LDL of less than 70 in such patients, and always had to start with moderate intensity therapy.
Okay.
fine. Yeah.
So, thank
Okay,
you.
Mita, continue. Yeah,
Yeah,
what
thank
are
you.
things?
Thank you, Dr.
Sarmate,
Nikesh.
Sarmate.
It was nice to know the mild, moderate, high, extreme high, and what to do, and the particular points, how much to reduce the LDL at each level was very important for us as a GP. When we see life profile, we can advise
No,
accordingly.
definitely, yeah.
Thank you. Thank you so much.
Thank you so much.
You want to mutate it?
Yeah, wonderful
Yeah,
interacting.
thank you, sir. Excellent one.
Thank you so much.
Yeah, all practical tips you had. Yeah,
Sure, sure,
thank
definitely.
you.
Sure,
See you
definitely.
Thank you
next week
so
again.
much.
Yeah, see you next week.
Yeah, sure, yeah.
Thank you,
Friends,
everyone.
Thank you.
And
next week he will take valvular disease
Valid disease.
problems and management.
Sure, yeah.
Okay,
thank
sir?
you. Thank you so much. Jaslok, Dr. Dalakia, Dr. Nikesh, everybody. Thank you so much.
Thank you, Mita. Thanks a lot.
Uh,
See you again on next Thursday, 6th
I
of,
don't
6th of November.
I don't know about it.
See, let us be.